All right, today we're going to build a clinical framework for treating visceral leishmaniasis, also known as Kala-Azar. And this isn't some abstract theoretical lecture. This is a practical primer. It's all about the essential info you'll need when you're face-to-face with this really challenging parasitic disease. Before we even touch on treatment protocols, you have to understand the stakes. And they could not be higher. Look, if you leave it untreated, the case fatality rate of fully manifest visceral leishmaniasis is over 90%. 90%. This is a disease we simply cannot afford to get wrong.
So here's our game plan. First up, we'll get a really clear picture of the disease itself. Then we'll check out our toolkit, the drugs we have to fight it. After that, and this is a big one, we'll dive into why treatment is so dependent on geography. We'll also cover some special patient populations. And finally, we'll talk about how you know if your treatment actually worked and what to do if it did.
Okay, so section 1. First things first, right? Before we can even think about how to treat something, we need to be crystal clear on exactly what we're up against.
So what is visceral leishmaniasis? Well, clinically speaking, it's a systemic disease. It's caused by parasites in the Leishmania donovani complex, and it's spread by the bite of an infected sandfly. The parasite then sets up shop in what we call the reticuloendothelial system, which basically means it goes right for the liver, the spleen, and the bone marrow. And that's what causes all the classic signs you're going to see.
Okay, now that we've got a handle on the disease, let's look at our armamentarium, our drug toolkit that we have to fight this thing. There are really 4 main players you need to know about.
First up, we've got the heavyweight champion, liposomal amphotericin B. It works by messing up the parasite's cell membrane. The key thing to remember here, it's got the highest efficacy and the best safety profile, which makes it the go-to treatment in a lot of places.
Next up, we have the old guard, the pentavalent antimonials, like sodium stibogluconate, or SSG. I mean, these have been around since the 1940s, and they're still in use, but they come with 2 huge problems: serious toxicity and resistance that's just everywhere. Seriously, if you're using these, you have to be thinking about cardiac monitoring. It's an absolute must.
Then there's miltefosine. And what's the big deal with this one? Well, its main advantage is massive. It's the only oral drug we have for VL. That's a total game changer for actually getting the medicine to patients. But, as we'll see, it's got some pretty major drawbacks of its own, especially when it comes to pregnancy. And rounding out our list is paramomycin. It's an aminoglycoside that messes with the parasite's ability to make proteins. Its main job these days isn't really as a solo act. Think of it more as a crucial team player in the combination drug regimens that are becoming more and more important.
Okay, so this table really puts it all together for you. You can think of it as your clinical cheat sheet. You've got liposomal AB, amazing stuff, but super expensive. Antimonials, cheap, but toxic and hitting resistance walls. Miltefosine is oral, which is great, but you can't use it in pregnancy. And paramomycin is a solid combo drug, but you've got to watch out for its own toxicities. Knowing these trade-offs is everything when you're making a treatment decision.
Okay, this next part is maybe the single most important concept in this entire explainer, so please listen up. Treatment for VL is not one size fits all. The number one factor that decides what drug you're going to use, it's geography. And that's almost entirely because of drug resistance.
Let's start in South Asia. We're talking India, Nepal, Bangladesh. Here, resistance to those old antimonial drugs like SSG is so bad, they're basically off the table for first-line treatment. Your go-to drug here, it's liposomal amphotericin B. Full stop.
Now, let's jump over to East Africa. You'll see a totally different picture. Here, that same drug, SSG, is still a first-line agent, but, and this is a huge but, it's only used as part of a combination therapy with paramomycin. Why? Because using either drug by itself just doesn't work well enough anymore. This is a perfect example of combination therapy becoming the new standard. And what about Europe and the Americas? The protocol changes again. Here, liposomal amphotericin B is the clear winner because of its great efficacy and how well patients tolerate it. And it's just as important to know what not to use. Turns out, miltefosine just doesn't work very well against the local leishmania species here, L. infantum, so it's not recommended.
This slide just drives the point home perfectly. Look at the difference. In South Asia, using antimonials first line, forget about it. But in East Africa, that same class of drug is still a pillar of treatment, but only if you pair it with something else. It's a perfect illustration of how local resistance patterns completely dictate what you do in the clinic.
All right, let's switch gears and talk about patients who don't quite fit the standard textbook case.
You've got to know how to tweak your protocols for these high-risk groups, because this is where a good outcome can really depend on making the right call.
So let's play out a clinical scenario. A patient comes in with VL, you run your tests, and they also come back HIV positive. Now, these two diseases together are a brutal combination. How does that one piece of information completely change your entire game plan?
Your entire plan has to shift to this three-prongs attack. First, you get way more aggressive with the anti-parasite drugs. We're talking higher total doses, often using combinations. Second, you get them on antiretroviral therapy for the HIV as soon as they're stable enough. And third, and you absolutely cannot forget this, you have to plan for long-term prophylaxis to prevent relapse, which is incredibly common in this group.
Okay, another really important group, pregnant patients. And there's one non-negotiable rule here. Miltefosine is teratogenic. It causes birth defects. It is absolutely 100% contraindicated in pregnancy. The drug of choice is liposomal amphotericin B. No question. This is one of those safety rules that you just have to burn into your memory.
All right, we're on the home stretch. You've picked your drug, you've treated the patient, now what? How do you know if it actually worked? This last section is all about that. The test of cure and what you do if things don't go as planned.
It's the most basic question, right? After all of that, how do we actually know if we've cured the patient?
And the answer is you follow the patient, not some number on a lab report. This is a huge clinical pearl. Test of cure in VL is all about the clinical signs. Is the fever gone? Is that huge spleen starting to shrink? Are they gaining weight? Those are your markers. And here's a big pitfall to avoid. Conventional antibody tests are totally useless for telling you if the patient is cured. They can stay positive for years, so you just have to follow them clinically for at least a year to make sure the disease doesn't come back.
And while you're following them, there's one more thing to keep on your radar, a condition called PKDL, or post-Kala-Azar dermal leishmaniasis. It's this skin manifestation that can pop up months after they seem to be cured. It's not a true relapse of the visceral disease, but it is a complication that needs its own long, specialized treatment.
So we'll end with this thought. We have a tiny handful of drugs that work, and the parasite is getting smarter every day. We've already seen that combination therapy is the new standard in places like East Africa. So the big question we're all facing is this it? Is combination therapy our only real strategy to protect the few drugs we have left and stay one step ahead of this absolutely brutal disease?